And so what about the toxicity? We've all been educated already to be a little scared of these products. The UPenn folks did a good job of getting us frightened. And it's basically cerebral edema and high fevers and confusion, and there's been some deaths on some of the studies. What do you take away from the presentation yesterday about that particular CAR-T product?
Well, so they had a 60% incidence of CRS, only 2% of grade 3.
CRS is cytokine release syndrome, yeah.
And only 2% had grade 3 cytokine release, and only about 4% of patients needed to use toxicity, the anti-IL-6 antibody. So what I took home from it, though, more was these therapies evolve and you get better. I'm not sure it's just the product, but it's also your management of the toxicity.
There's a learning curve
exactly.
to all of these treatments.
Oh, I was sort of impressed it was not very toxic. That's what I thought you were going to say.
Right.
Sagar, what did you think?
I mean, to me, so there's two issues. There's CRS and there's neurotox. CRS, to me, is like tumor lysis syndrome. You just got to figure out how to deal with it. And there's a certain amount of experience that comes with it, but certainly it's not a reason not to use the therapy. The neurotox is a different story, and I think the mechanism on that is not quite as clear. The management is a little bit more challenging, but fortunately that's a rare event. I mean, it doesn't mean it doesn't happen, but it is a rare event. What struck me about the presentation yesterday, despite all of these sort of, it wasn't 18, it wasn't this, it wasn't that, the median PFS was 4 times longer than it was for CD19 in large cell lymphoma. 4 times longer. That's pretty good, I think.
Ed, should we be using this much earlier in the treatment course? How early are you going to go with CAR-T
Well, that
therapy?
goes along with the engineering issue. Currently, the vast majority of these patients are very heavily pretreated and in their last legs of their life. And the immune system, the T cells in particular, can be very damaged, and that may account for manufacturing failures for these things, lack of persistence. There seems to be a real association with the persistence and expansion of these cells. And so I think there's a lot of, and I think these results are promising enough, but think of the results of what the study that was presented in the relapsed refractory setting. So just like when we first were studying daratumumab or bortezomib, in that setting, we saw very exciting responses, but they were potentially not as durable or as curative. And then we started moving these treatments earlier and earlier, and we're seeing better and better responses. So yes,
and daratumumab don't cost $400,000.
well, if
you keep it going for 10 years,
if we can give one spritz, it may be worth it. So, so yes, I think there's a number of studies that are moving earlier and earlier in the course of the disease. There's also different targets that, you know, CD19-directed CAR T cells are what have been approved in acute lymphocytic leukemia and in non-Hodgkin's lymphoma, and that seems to be a wonderful target in that setting. In multiple myeloma, BCMA seems like a very rational target since it is expressed very frequently, but perhaps other targets like CD38, CD19 perhaps is in the group of the cells that are the most resistant, maybe combinations of these cells, maybe combining other immunotherapies with these cells. So I think we still have a lot of work to do, but certainly the initial results are very promising.
Yeah, my take on listening to some of the lymphoma people talk about this too is we're still in the very early days of understanding how to manage this and improve on it, which we will. Sagar, there are other drugs that target BCMA that have been talked about. What's getting you interested in the non-CAR-T BCMA space?
Yeah, I mean, I think BCMA is the ideal target, and I'm going to stay away from Ed's reference to the CD19 stem cell, which he snuck in there. But
no
I think,
question, that's the correct target.
But BCMA, I think, is really exciting, and there's an antibody-drug conjugate. The DREAM study was presented at ASH and looks really good in a larger phase 2 study is now being done to just
Yeah, they had about a 60% response rate in pretty heavily pretreated patients.
60% across the board. Yeah, if you look at DARA-resistant, it was about 50%.
And what about eye toxicity? That came out as an issue. Are you worried about that?
Well, I think that it's a learning curve in terms of how to manage it. It's a known side effect of the immunotoxin that's associated with the antibody. So I think we'll just have to see with the mitigation strategy in the current phase 2 whether that's sufficient to reduce the severity of the corneal toxicity. It is reversible in almost all the patients.
BCMA bites or bispecifics, anybody had any experience with those yet, or just excited to try?
We have some other bispecifics and with very encouraging activity. I think to kind of compare it to the CAR T, it goes back to the patient selection. You know, here, it's an off-the-shelf product, so I think that's important when you're picking the right patient. And this is going to be, again, a sequencing issue, because if you do give these BCMA drugs currently the way the CAR T studies are written,
like the bites or the
they're
antibodies,
excluded.
yeah.
So I think we have another sequencing issue, so you want to make sure that you're doing the right thing for the patient.
All right, well, thank you very much. CAR T, I think we'll be talking about that for a long time to come.